middle of the lush and prosperous Sundanese area, which is rich of various culture, and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society. Nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior, with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Pajajaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, Basic Science Service Center, Language Center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Pajajaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Pajajaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Pajajaran, straightening and developing together with society. From West Java, for Indonesia, to the world through SDGs.
Greeting.
Are you interested in learning about Cleft and Palate with experts from around the world? And you can learn this for free while gaining 3 credits. Come join our online course in collaboration with Faculty of Dentistry Universitas Pajajaran and Smile Train.
Greeting from Transcendent 2021, massive open online course in Cleft and Palate by Faculty of Dentistry, Universitas Pajajaran, in collaboration with Smaltran and YPPCBL. My name is Alia Intan. I'm student from Faculty of Dentistry, Universitas Pajajaran. So, for the participant, good morning, good afternoon, and good evening. Greetings to Professor Kikelomo Kolawole, Consultant of Child Dental Health Department, Obafemi Awolowo University in Nigeria. Thank you for being here, Professor. It's been an honor for us, and we really appreciate your presence here. How are you, Professor?
I'm very well, thank you.
Very great. Thank you for giving us your time here. Hope you are doing well and stay healthy. Also, here we have Dr. Gigi Lisda Damayanti, Specialist Prosthodontia. How are you, Doc?
I'm good, thank you. How are you too?
I'm good too. Thank you, Doctor, for being here. At last, greeting to all of the participants. Thank you for participating in this course and attending today's live discussion. So today is our first live discussion in the second week. It is about Nasoalveolar Molding for unilateral and bilateral cleft lip and palate clinical steps. Today's live discussion will be separated into 2 sessions, which is the first session is the professor will be answering the question that have been filled by the participants in the website. The question will be presented by the committee through the screen. And in the second session, the participant have the opportunity to ask the professor directly or maybe from the comment section. So without any further I would like to give the spotlight to Dr. Lisda and Professor Kikelomo. Please, Doctor and Professor, time is yours.
Thank you.
Thank you for the time, MC Alia. Good afternoon, ladies and gentlemen, the participants of this MOOC, Massive Open Online Course Seminar. It is an honor to attend this educational event about cleft lip and palate. Before we started, I would like to introduce Prof. Kikelomo Kolawole from Obafemi Awolowo University, Nigeria. As our speaker today, and she will be talking about nasoalveolar molding for unilateral and bilateral cleft lip and palate. Good afternoon, Professor. How do you do?
I'm good, and you?
Okay, nice to meet you too, Professor. What time is it now?
9 a.m. It's 9
9 a.m. 6 hours different for our city, Bandung. Thank you for providing time to attend this event. And also, I would like to introduce myself as moderator for today. My name is Lisda Damayanti. I'm lecturer at Prostodontic Department, Universitas Pajajaran. Now we can start for discussion, Professor.
Yes.
Now, let's move on to some question and answer. The committee, you may share the first question, please. First question, I think the question from one of prostodontic resident professor. The question is how to control the pressure from the lateral strapping so as not to give the effect of excessive pressure in cases of bilateral cleft.
Thank you. Can I go ahead with that? Can I go ahead to answer that?
Yes, yes, yes. Yes.
Okay, thank you. For both unilateral and bilateral cleft, thank you for that question. It's a very good one. For both unilateral and bilateral clefts, the objective of the strapping is not so much to apply pressure. Yes, it does apply pressure, but the major objective is to bring the segments of the lips together. So for a unilateral cleft, the taping or strapping usually is from the non-cleft side to the cleft side, and the objective is to bring the nasal septum and the philtrum that is deviated back to the midline. For the bilateral cleft, the objective is to bring the three segments together, the prolabial segments and the right and left segments. So what you do with the bilateral cleft is to use your fingers to bring the three segments together and then strap the lip. So it isn't so much as applying pressure, but bringing the lip segments together. That said, it does apply some pressure, but the presence of the plates in the patient's mouth is able to control the pressure. The pressure from the strapping is not transferred directly to the alveolar ridge because of the presence of the plates, which covers the entire premaxillary segment and the left and right segments in the case of the palatal cleft. I hope I'm clear.
I think it's very clear answer, Professor. Control the pressure from the lateral strapping with cases cleft lip and palate, whether bilateral cleft. And Now we second question, please. There are some questions from resident prosthodontic specialist, our faculty. For your information, Professor, prosthodontic specialist program in our faculty also is doing treatment for infant with cleft lip and palate using name combined with nasal stent, strapping extraoral as a part of
the prosthodontist.
yes, as a part of my yes, Professor.
I said the prosthodontist is an essential part of
As a
the
part, yes.
That's good.
Prosthodontist is a part of maxillofacial process is at the government central hospital in Bandung City. Locally, the amounts of infant with condition is quite a lot in our city. Almost for every week, we give treatment for 1 or 2 new cases of infant with cleft lip and palate. How is the prevalence of cleft lip and palate in Nigeria, Prof?
Well, we say we have about 1 in 10,000 bats. And so it's not too common an occurrence. We don't find patients on a weekly basis. Sometimes for many weeks or even months, we don't see any patients with cleft. Sometimes it's also seasonal. And sometimes we think the reason we don't see many patients is due to the poor awareness, the low awareness amongst our general population.
Is it more unilateral or bilateral cleft lip and palate cases?
We see more unilateral cases.
Okay, I see. Okay, the next we move on to the next question. How effective is the use buttons in unilateral cleft case? How effective is the use of buttons in a unilateral cleft case?
Thank you for that question.
The question from one of prosthodontic professor. Yes.
Thank you for the question, but I'll require some clarification. I don't know exactly what the person is referring to as buttons in this case.
The button, it means retentive button with retentive button places in NAM for unilateral cleft to strapping extraoral display placement.
Thank you, I get you. Because in the original Grayson's method, the retention sticks were used both in the unilateral and bilateral clefts. But most of what we do is the modified Figuero's and the modified Grayson's method. And so we don't often use the retention buttons in unilateral cleft cases. For retention, we rely more on relining the plates. Usually we use soft tissue reliner. We use Durabase. And then the other thing we rely on for retention is the denture adhesive. And then together with the strapping of the lips, most of the time we are good. We do not often use retention sticks for unilateral cleft lip and palate in my center. But I know that the original description by Grayson advocated the use of the button both for unilateral and bilateral clefts. And strapping was done extraorally for both unilateral and bilateral cleft. I think the major objective was retention, and we've been able to get around that with both the relining and the use of denture adhesive. Thank you.
Thank you, Professor. I think it's very clear answer. The next question, please. Number 3. The next question. How to find the right elastic size for getting the right pressure for the lateral strapping?
Thank you for that question. I think what the person is referring to is in a case of bilateral cleft lip and palate, where we use orthodontic elastics. What is advocated? I learned to do NAM from the Changong Memorial Hospital. So I've been following their own recommendations and their protocol. And so what they recommend is the 4M, the elastic that is 4 ounces, which delivers medium force. The orthodontic elastics come from the low to very low to medium, and then heavy forces and very heavy forces. But what we use is the medium, which has about 4 ounces of force. And what that does is that by the time you stretch it to 2 times the size, it delivers about 100 grams of force when you are strapping to the lip. So what we use is the 4 ounces, which is the medium, that gives medium delivery of force. Thank you.
And the diameter of the elastic is 4 millimeter, Prof?
That's not the diameter.
Elastic orthodontic? Usually often for strapping extraoral, diameter 4 millimeter.
The diameters also vary. The diameters vary. It depends on the choice you are going with. We have some, you see it's labeled 5/16, 1/3. The diameters also vary, but what we often use is the 5/16 diameter.
Okay.
Usually
Okay, Professor.
we have them in our collection for use with our orthodontic patients. So we just pick from what we have in our collection.
Okay, I think it's very clear answer for that question. Now the next question, please. From Edwina Maharani, one of the resident prosthodontic resident in our faculty. Is it better when the baby cry while we taking impression, or just make sure that the baby is awake? Because I think it is easier for us to know that the baby is breathing when she or he is crying.
Thank you. That's an interesting one. You know, we always say that it's better for us when the baby is crying too, because that's where you're sure that the baby is really, really awake and aroused. We appreciate the risk involved in taking intraoral impressions for these infants. And so because of that, we prefer to, we try to, you know, people have brought forward various positions for taking the impressions just to ensure safety. What is paramount at this impression taking period is safety. So when the baby is crying, it makes it very clear that the airway is patent. And so when the baby cries, we like the fact that the baby is crying. We know that the baby is awake. We know the baby is well. We know that the airways are patent when the baby is crying. But we try to make sure that the impression taking is done very quickly, the material sets quickly, so that this period of discomfort for the child is not protracted. Thank you.
The impression material, elastomer, heavy body, Prof? Use heavy body elastomer?
I use heavy body. I know that where at the Changong Memorial Center in Taiwan, where I learned this, they also use alginates. but I don't use alginates for safety reasons. I find it easier to manage the heavy body material, which we just need and load on the plate.
Yes. Thank you, Professor. Very insightful answer. And now, next question. Please, the committee. From Evander Reynaldo, one of the prosthodontic resident in our faculty. I've seen some PNAM use likely orthodontic loop to activate nasal stent. Is it more effective than straight nasal stent?
Thank you. I think that is also optional. I think it's also optional. When with Grayson's method, he actually used a nasal stent that at the end was actually even bilobed. But I think what you use depends on what you are used to. I know that we use the loop as a nasal stent because it makes it easy to adjust the nasal stent. When you have an orthodontic loop of wire, then it means that manipulation of the nasal stent is very possible and it's more flexible than when you have a whole bunch of acrylic, solid acrylic as the stent. So the benefit of the loop really that is incorporated is to facilitate manipulation of the stent. I don't think it's because it's more effective, it's to facilitate manipulation of the stent. Because if you have the loop, it means you can move up and down when you're trying to activate it. You can move sideways. It's easy to adjust than having to adjust a whole block of acrylic, which would have set, which would require so much more extensive trimming. Apart from that, the other variation to the stent that I'm aware of is that we use stainless steel wire to create our loop, but some centers have also postulated and advocated the use of TMA wires, beta titanium wires. I know that Professor Eric Liu at the Changong Center advocates that, but I think it's really what works for you. The advantage of the orthodontic loop is to facilitate manipulation of an adjustment of the nasal stents as required. Thank you.
Thank you, Professor, for the answer. And I think the answer is very insightful from question Evander Reynaldo. And next question, please. From Maulida, a student of Universitas Pajajaran, could you elaborate more? Why is it challenging to obtain optimal aesthetic result, especially in BCLP? It means in fun with cleft lip and palate.
Yes, thank you for the question. I guess that came up from the introduction I included in my slides. I think the reason why it's more challenging to obtain optimal aesthetics with the bilateral cleft lip and palate, it goes back to the defects that exists from the beginning. So I would explain that when a child with a unilateral cleft lip and palate is born and a child with a bilateral cleft lip and palate is born, if we look at the defects that they present with, we would see that usually in unilateral cleft lip and palate, you have a normal side, and then on the other side, you have the deviated alar cartilage, you have the nasal, the columella that is the base is deviated to the non-cleft side. You have sometimes shortening of the columella. But with the bilateral cleft lip, because you have discontinuity on two sides, it's possible that your alar cartilages are totally flat. In the unilateral cleft lip and palate, you still have some of the nasal tip, which may be deviated to one side. But when it's bilateral, it's totally flat. Sometimes the prolabial tissue lacks any tissue at all and is grossly displaced. Sometimes it's rotated. And so the initial deformity is what makes it challenging to get optimal results with bilateral cleft lip and palate compared with the unilateral cleft lip and palate. You almost have a totally flat nose. The columella is extremely shortened. The prolabium is directly at the end of the nose, and sometimes the deviation is quite extensive. That's why it's more difficult. The deformity with a bilateral cleft lip and palate appears more severe than what you have with a unilateral cleft lip and palate, and that's why obtaining optimal aesthetics can be also more challenging than the unilateral cleft lip and palate. Thank you.
Okay, thank you for the answer, Professor. The next question, please. How to determine the right modification time of NAM device so that there won't be a lockout segment occurring instead of a molding of the alveolar segment? Is it okay to generalize a weekly modification of the device in every patient?
Thank you. Let me read that again. Determine the right modification time of NAM so that there won't be a locked out segment occurring instead of the molding of the alveolar segment. Thank you very much. Traditionally, we say that we check the device every week. A weekly appointment is what is traditionally advocated, recommended, that the patient comes in every week so that where there are challenges, you can pick the challenges and you can continue with the molding. I think if the plate is properly made, it's supposed to cover the entire premaxillary segment, depending on the method you're using, whether it's the Grayson's method or the Figuero's method. So when it covers the whole of the cleft region, the premaxillar and the left and right segments, or even when it's just the left and right segments in a unilateral cleft, the aim is that the plate covers the segments well enough so that when the segments are, the NAM is having its effects, it's just bringing the segments together and not sending it out. The movements are controlled and they are gently done. You see that what is advocated is that when you are trying to do the molding occurs both with the strapping of the lip and then the sequential addition of the molding material, usually the tissue, the soft tissue reliner that you put on the lateral aspects, and then the trimming that you do on the mesial aspects to make the segments come together. So I think if the plate is covering this entire segments properly, you are not likely to have a locked out segment. But be that as it is, we try to see patients on a weekly basis so that nothing really goes wrong. And when anything is going on, you can catch it on time. But occasionally we have patients who are unable to come in on a weekly basis. And so sometimes we deviate from the weekly appointments for a patient that is unable to make it. Thank you.
Yes. Thank you, Professor. Very insightful answer. I think there is no more question for share screen, but if there is any other question to be asked directly right now, participants are able to raise their hand, please.
Oh, I can see a question on the screen.
Yes.
How to keep NAM stay in the oral cavity? Do I take
yes,
that?
Yes. How to keep NAM? Oh, I'm sorry, Prof. How to keep NAM stay in oral cavity of a CLP patient, because some babies with active masticatory muscle and tongue can release NAM out of their mouth. How to keep NAM stay?
Thank you for that question. I think what keeps the appliance in the mouth, we try to make a plate that fits as well as it can, but also alongside with that, we usually reline the plate at the first visits when you want to deliver the appliance. You reline directly in the patient's mouth to get a good fit. Apart from that, the denture adhesive, which we use for our own technique, helps to keep the appliance in place. We have various types of denture adhesives, but we often use, they're off-the-counter products, and so we use Polydent. Sometimes we use other types too. They also help to keep the appliance in place. And then lastly, sometimes the nasal stents may be slipping out of the patient's nose. The strapping also helps to keep the appliance in place. When the lips are strapped together, it adds to the retention, as well as putting a little strip of the tape on the nasal stents. That also helps to keep the appliance in place. But most of the time, when a child is given the NAM appliance as soon as possible after birth, it helps the retention, because once they are used to the presence in the mouth, they don't try to send it to propel it out of the mouth. They are adjusted to it and it feels normal with them. Thank you.
Thank you, Professor, for the answer. To keep the name stay in oral cavity of infant with cleft lip and palate. Is there any question from share screen?
That's all, Doc.
Okay.
Now we open the change for the participants in the Zoom to ask directly or by the chat. So for the participants, you can ask directly Professor Kikelomo by raise hand online, so we can know that you are having a question.
In Nigeria, Professor, in Nigeria, is orthodontist doing treatment for CLP patient?
Well, I will say yes. In my center, I can speak convincingly for my center. I think we still have varied opinions about it. There was a session we had with the Smile Train yesterday. I didn't participate at that session, but they were having a discussion on to do or not to do NAM, because people feel the long-term benefits may not be so exciting. But for me, in my center, for patients that come, and together with our Cleft team, our surgeons are now used to NAM. And so when the patients come in with the clefts, they refer them, they send them straight to the orthodontist to do this NAM procedure for them before the repair of the lip. So we get to do NAM in my center. We do Nasoalveolar Molding for our patients when it is necessary and when the patients present to us. I'm sure sometimes we may miss a few patients, but the majority of our surgeons in our Cleft team, they believe in NAM, and so they send patients to us.
Okay, Prof, there is question from Detinetami, one of a prosthodontic resident. Can you explain how to achieve nasal symmetry in unilateral cleft lip and palate infants treated with PNAM, and how long basically the patient should be treated with PNAM to get that symmetry?
Thank you for the question. Well, to achieve nasal symmetry, I think I should address that first. It's not only dependent on NAM. And I think this is where a number of people get it wrong. because they imagine that what NAM advocates that it would achieve is much, they imagine that NAM advocates it would achieve much more than what the goals of NAM are. So when the integrated approach to managing cleft patients now recognizes that first, if you do nasoalveolar molding, you reduce the severity of the initial deformity, that is at that pre-surgical stage. There's a stage of surgery where a lot can be done to achieve symmetry, the surgical techniques that are advocated to get maximum symmetry. And then there's a post-surgical phase of retention where devices like nose up, silicone retainers are used to maintain the results you have achieved. So basically what I'm saying is that NAM alone is not what achieves optimal nasal symmetry, but it does help as the pre-surgical stage of manipulation and reshaping the nose. NAM works best when a patient is seen in the immediate neonatal period, because that is when the cartilage has maximum malleability and you are able to reshape and mold it. So ideally, nasoalveolar molding should start in the first week of life and extend until the third month of life, or until when the patient is ready for surgery, because some patients are not ready for surgery on time because of things like low weight and or any other thing. But we know that the effect of this plasticity of the cartilaginous tissue wears away after about 6 weeks, because the plasticity is also dependent on the maternal estrogen that is still present in the baby in the immediate neonatal period. So we advocate that NAM is done in the first 3 to 4 months of life, and that it should be started as soon as possible, preferably in the first week of life. At the first presentation of the patient, the minimum that we should try to do is to tape the lips together after we have taken an intraoral impression, and try to deliver the plates as soon as possible, possibly in the first or second week of life. Thank you.
Thank you, Professor, for the answer.
And
And the next question, maybe? Is there any question? Oh, from Vita Mulya, the lecturer prosthodontic in our faculty. Is it acceptable to use denture adhesive for infant for long period? Is there any special guideline to use it?
Thank you. Use denture adhesive for these infants, and we've been using it without any problem. The guideline with it is that we use as little as is necessary. We don't use too much of the adhesive. We try to put majorly in the alveolar tuberosity region and sometimes a little anteriorly. All we need is something to hold the plates in place. If the plate has been properly relined to, some of them can even stay in place and have good enough retention without the denture adhesive. So what we do is minimal use. The other guideline is that once the plate is removed from the patient's mouth, we try to clean, we instruct the parents to clean out any leftover adhesive in the patient's mouth to prevent ingestion or aspiration. So once the plate is removed from the patient's mouth, the advice is that the denture adhesive that may be sticking to the alveolar ridge is cleaned out thoroughly with cotton wool and just water to make sure that there is no leftover. And then the plate is cleaned also on a regular basis, because the adhesive is quite sticky. You need to clean it off from the plate and make sure the plate is clean every morning before putting fresh adhesive. So there is no special guideline. We use for about 3 to 4 months, depending on how long the patient uses the appliance, but we have not had any reactions to the adhesive or any complaints about any adverse effects from the adhesive. Thank you.
Yes. Thank you, Professor, for the answer. And I think denture adhesive to increase retention, Professor, for NAM, Nasoalveolar Molding. And it's okay, use denture adhesive, yeah, for 3 or 4 months for infant with cleft lip and palate.
Yes. Thank you.
Yes, thank you, Professor. Is there any question in share screen? No?
No, Doc. That was the last question.
Yes, that's the last question. Thank you very much, Professor, for interesting discussion. So we can improve our knowledge about the treatment of infant with unilateral, bilateral, cleft lip, and palate with nasoalveolar molding. Professor, if you have anything to share for us about this interesting topic.
Oh, okay. So I was going to ask, would I get this recording, because I found the questions quite interesting too, and I've also benefited from this session tremendously. Will I be able to get the recording of this session?
Alia.
Okay. Doctor, but I think there is still one
Oh, there is
question
still one.
in the chat.
Yes.
Yeah.
There is still one question, Professor.
This is the last question, maybe for today.
The question is, I've seen the patient with overlapping major and minor defect. How to stretch the distance between the defect, or just leave it?
Sorry, I hope I get that question right. I think I don't really get what the overlapping major or minor defect is, but let me attempt it. If what the person means is that there is a large defect, and I'm not sure if he's referring to the defect of the lip now or of the alveolus. Because he said stretch, I think it may be the lip. When you tape the lips together, I think gradually with time, you see the lips come together and the defects become smaller and smaller as the treatment progresses. Even with the alveolar ridge, as you put the tissue conditioner, the tissue reliner on the lateral aspects, and you continue to mold, the alveolar ridge defect also becomes smaller because the tissues are so malleable and pliable at this time. So the defect becomes smaller. So I don't think, no matter how large this defect is initially, even when you have really protruding prolabium or anterior maxillary segments, by the time you tape the lips together, they usually come together after some time. You continue to observe the patient, you find that the lips, the segments are actually coming together, both the lips and the alveolus. So it's always beneficial to attempt NAM in such patients where the defect is major. Instead of leaving it, we can reduce the severity of the defects before a patient goes in for surgery.
Yes, thank you, Professor, for the answer. The committee, is there any question from their screen?
That is the last question, Doctor.
There is no question.
Yeah.
Okay, Professor, thank you very much for the interesting discussion. I will conclude about discussion today. NAM is not only the reduction of the size of cleft, also the active molding and positioning of the surroundings, soft and hard tissue and cartilage. The basic goal of any approach to cleft lip and palate repair, whether for the unilateral and bilateral anomaly, is to restore normal anatomy. Finally, I would like to express our gratitude to Prof. Kikelomo. We hope to meet again soon in person, maybe someday, to share the cases and treatment in fun with cleft lip and palate.
Thank you so much, Prof.
Thank you. Hopefully this discussion and information about NAM that we have shared today would be useful for all of us. Thank you again, Professor, and all participants for your great attention. Back to Elia. Thank you.
Thank you so much, Dr. So, Professor, sorry. Also, if you want the record, I will send you through email, maybe.
Thank you. I just want a compilation. Want to look at the questions all over again.
Okay. Okay, I will send it by email, Professor.
Thank you so much. I'm grateful.
Okay. So, participants, this is the end of today's live discussion. But before, we're going to the photo session first. Maybe the participant can turn on the camera before the committee taking shot of the screening. Okay, I will lead. We are start from the first page. Okay, 1, 2, cheese.
Cheese.
Okay, next to the second page. Okay. 1, 2, cheese.
Cheese.
And the last page. Please, committee. Okay, 1, 2, cheese. Okay. Okay, before I close today's session, I would like to send my great gratitude for Dr. Lisda as the moderator, and also Professor Kikelomo, who already make time for us in this today's live discussion, and also in these hard times of the pandemic. We can still see the bright side, right? We can still doing this international course, and I believe this will be an inspiration for all of us. For further, we can give our best treatment for our cleft patients. So thank you very much for everyone. Goodbye and stay healthy.
Thank you so much. It's been a pleasure being with you this morning. Thank you.
Professor.
Thank you, Professor.
Stay healthy and happy, Professor.